Hello, good day, good afternoon, everyone. I'm Dr. Brian Slomovitz. I'm a gynecologic oncologist here at Mount Sinai Medical Center in Miami Beach, Florida. I also serve on the GOG Board of Directors, and for the GOG Partners Group, I'm the endometrial cancer clinical trial lead. It gives me great pleasure today to welcome you to our webinar on developing a guideline-based care model for patients with endometrial cancer in the adjuvant setting. I'm really excited about this. We're spending a lot of time on endometrial cancer, both in research and patient advancements lately. So I think it's really appropriate to have this now, and I look forward to a very active discussion. To remind you, as you have questions, please just text them in the box and we'll get through them either during the discussion or afterwards. Now, it really gives me great pleasure, and I'm honored and humbled to have two great participants working with me today. Both from The Ohio State University in Columbus, Ohio at the James Cancer Center. First is Courtney Arn. She's a nurse practitioner who works with the Gynecologic Oncology group there. Courtney, say hello.
Hello. Like Dr. Slomovitz said, my name is Courtney Arn. I'm a nurse practitioner who works at The Ohio State University, and I've been working with GYN oncology patients for the last 10 years now.
Great, thanks, Courtney. I'm really happy that you're here, and I'm sure that you're going to add a tremendous amount, particularly from the patient symptoms and the patient aspects that sometimes as physicians we don't see. And then I'm really an honor to welcome my good friend. I've known Dave for many, many, many years. Dave O'Malley, he's the division director at The Ohio State. Dave, do you want to introduce yourself?
Oh, thanks for having me, Brian. I really appreciate it. Thanks to Medscape for this wonderful opportunity to discuss endometrial cancer. I'm honored to be at the director of the Division of Gynecological Oncology, as well as our work in GOG that you alluded to. Also a member of the board of directors, and I help lead the ovarian cancer portfolio. But really excited today to be talking about endometrial cancer.
Yeah, thanks, Dave. And for those out there that don't know, Dave really led the pivotal trial, one of the more important trials in endometrial cancer, looking at pembrolizumab in the second-line recurrent setting, really making it the standard of care there. So it's really, again, an honor to have Dave here. And I know he and I and Courtney are excited. Moving some of these therapies into earlier lines of therapy can give our patients better options and better ways to treat this cancer. So welcome to both of you. In this program, I just want to go through this quickly. We'll discuss, we're going to review the guideline specifics to the adjuvant setting. Talk about biomarker testing, some advancements there, risk factor analysis, and how that drives treatment options, what some of those treatments options are, give some clinical data in the adjuvant therapy, in the selection of management, selection in the patients who require adjuvant therapy. And then from there, talk about the what we're doing for the advanced and the metastatic patients in the first line setting. An underlying theme here, showing our excitement about immunotherapy and how it's really incorporated into the care for many of our patients. So first, we want to talk about some biomarker testing in endometrial cancer. There's 4 molecular subtypes which have been identified that help predict tumor behavior, prognosis, and treatment options. And these 4 groups, and I know I'm going to get to a little bit more specifics, but POLE, or the ultra-mutated endometrial cancers, those with microsatellite instability, the copy number low, the P53 wild type, also known as the no specific molecular profile group. And finally, the copy number high, or the P53 abnormal patients. Dave, you and your team, you're leading a great team at The Ohio State, which I know you're a great leader there. One of your investigators, Casey Cosgrove, he's really, I can't say junior anymore, a mid to high level investigator, but really a rock star in helping us to develop and expand on our knowledge of these 4 groups. Can you take us through these a little bit and tell us how these subgroups have helped to better the standards of care you're offering to your patients?
I think we're starting to really look at not only the histology and the stage, but also the molecular subtyping. We're really, first thing we do is check, are they DMMR? And with that, then going down to, are they P53 mutated or not? And you see here on the right where the P53 abnormal is the worst prognosis. But then when we have this copy number low or non-specific molecular profile group, again, we need to start looking at the differences. We're going to talk about some of that data in their outcomes based on chemotherapy, radiation. We still continue to struggle with the POLE mutation, how we really how we're doing that in our own pathology, because ultimately we'd like to have POLE mutation on all of our patients. But right now we're taking it as a case-by-case basis, particularly when we see some histological changes, which make us think that there may be a POLE mutation evident. So again, we're trying to continue to work to improve the efficiency in these processes, but every patient, DMMR, every patient P53, we're also getting ERPR and then utilizing a case-by-case basis on the POLE mutations.
Yeah, no, thanks for that. And you mentioned how, sometimes we're not getting POLE, which is okay. In my institution, I don't get it all the time. I mean, the good news is a lot of those patients do well. And I think we'll in the future get to some more de-escalated therapy. But, Courtney, Dave went through the risk factors nicely. When we sort of, I want to talk about this now a little bit, and then we'll talk about stage. But when we see a patient who comes in with clinic with a P53 mutation, with this copy number high subgroup, we know it's not going to be the traditional one and done, just surgery. How are, as a clinician, a physician extender, how are you talking to these patients differently, even at their first interaction? Because, I know those are the patients, as we all know, we're going to get to know a little bit more and follow them a little bit longer.
Yeah, I think, the advanced practice providers are more involved in the patient's care who do require adjuvant therapy. And I think patient education is really important. So one of the first things we do is we start talking about the treatment plan, including the schedule, potential side effects, how we're going to manage those side effects. But the most important thing we do is we talk about signs and symptoms that they need to report to us so that we can have early intervention to help minimize the toxicities.
Yeah, no, that's spot on. We'll talk about that a little bit more. One of the things that Dave sort of went through, and I just want to highlight here, when we talk about the DMMR group, we're not only identifying a better treatment option for some of those patients, but oftentimes those are the patients that may have a hereditary cause of their endometrial cancer. And in my patient population, a lot of them may be due to something called promoter methylation, but we also do hereditary genetic testing to see if, in fact, they have something called Lynch syndrome, which was a predisposition to developing those cancers. Let's move on. And, Courtney, I want to get a little bit of your some more feedback here, because you sort of alluded to this. I want you to expand a little bit. This is the staging system for endometrial cancer. I will say in 2023, we updated the staging system. Whenever we update a staging system, it takes a little bit of time for clinicians in practice, like all of us, to really incorporate it into our standard, into our care and understanding. I will say that there was an incorporation here of the molecular classifications. So it's nice that we, even though it's not universally done, it's nice that we brought that in. But beyond that, Courtney, again, you're seeing patients that on their post-op visit, some of them are stage 1. Truthfully, I know you're a big referral center. You may never see them again. You'll send them back to their providers. But you're seeing some of these more advanced patients, and there's a lot of different things you're doing, including bringing in some other services. Tell us some of your thoughts on this discussion with your patients.
Yeah, so the early stage or lower risk patients, we do see them. We have a survivorship visit within 3 months of their surgery. And at that visit, we talk about their diagnosis. When patients are diagnosed with cancer, it's kind of a whirlwind for them. And so it's an opportunity to really kind of pause, explain to them what type of cancer they have, what that means. We talk about their follow-up care. We also talk about signs and symptoms of cancer recurrence that they should be looking for or calling in if they're having. And we just kind of explain to them what, the next 5 years of their surveillance visits will look like. For the patients who have more advanced disease and do require adjuvant therapy, we talk about, again, the treatment plan, the potential side effects of the treatments, what their life is going to look like while they're receiving treatment, and then talking to them about signs and symptoms that they should be reporting to us from a side effect profile from their treatment.
Great. No, that's that was a nice overview. And the other thing it's sort of doing, it's introducing us to where we're going to go when we talk about adjuvant therapy. It's even if there's no measurable disease after surgery, it's going to be a select group of stage 1 patients, and then the stage 2, 3, and 4 patients who are going to get adjuvant therapy. And let's move on, because we're going to talk about the different options as we're there. So this is the question: how does risk factor analysis, stage, histology, molecular classifications really drive our treatment options in the adjuvant setting? here's two landmark studies that I sort of want to introduce. Then Dave, I think I'm going to turn to you to get some feedback on into incorporation in our practice. The first one being GOG 258. This was a randomized trial looking at chemotherapy with radiation therapy versus chemotherapy alone in newly diagnosed stage 3 or 4 patients with curative or stage 1 or 2 patients with a high risk histology, serous or clear cell, curative intent. So there's no disease present, but we're looking for the best adjuvant therapy, less than 2 centimeter residual disease. The primary endpoint here was recurrence-free survival or disease-free survival. And similarly, the contemporary study was PORTEC 3. Similarly, radiation chemotherapy versus radiation alone, newly diagnosed endometrial cancer patients at high risk for recurrence. Stage 1 grade 3s with deep myometrial invasion, endometrioid histology stage 2 or 3, and similarly, the high-risk histologic subtypes, stage 1 through 3 with no residual disease. Let's talk through some of the results. And Dave, here it is. Okay, GOG 258 found that the 5-year recurrence-free survival with chemoradiation was the same as chemotherapy alone, no difference in overall survival. And similarly, in the PORTEC 3 trial, comparable results, except we'll go through the molecular classification in the next slide, but maybe some differences. So take us through this. Here are the results. This was reported out in one of the big scientific meetings we went to. I think 258 was at one of the ASCO meetings, but how did this data affect your standard of care?
Well, the big group you're missing here is no radiation, right? So they all had external beam radiation. So the question still continues to be, how much does radiation add to the overall treatment paradigm? And we have never had a radiation trial which showed improvement in overall survival. And we just updated 258, it was just published with regards to the overall survival. And not only is that a benefit, if anything, there's a slight trend towards worse in the radiation arm. And is that because of secondary malignancies? Is that because the morbidity associated with long-term radiation? So to me, what 258 said was you absolutely have to do chemotherapy in these patients. If you're going to do one treatment, it's chemotherapy. Okay. Now, PORTEC 3 is more interesting in that it was much more of a localized group of patients, which again, looking at the missing arm, which is just vaginal cup brachytherapy versus observation or plus or minus chemotherapy, I should say. So we look at this group of patients, there is a group, and we saw this histology that benefited clearly from chemotherapy. How much is radiation added? We're going to talk about B21 in a few minutes with regards to some of the deficient patients in the molecular subtype. So for me, if I'm going to do one therapy, an advanced stage patient or in a patient who's a serous cancer, it's going to be chemotherapy. How much more does radiation add continues to be called into question. It's beyond local regional control, which has radiation is clearly shown. But how much are we going to sacrifice long-term morbidity? The most underreported toxicity in clinical trials is long-term morbidity from radiation. Chemotherapy, if you can only do one treatment.
Yeah, no, and that was a nice overview. I think, my quick summary of that is, yes, based on 258, my patients with stage 3 or 4 disease, chemotherapy, I really try to limit the radiation because of its effect on the bone marrow reserve. And, with chemotherapy, we need to preserve as much bone marrow as possible. And the same thing with PORTEC, to your point, a lot of comparable outcomes, but the chemotherapy seems to drive most of the groups. And I want, with that, I want to focus on this top group here. Now, this is looking at PORTEC 3 by the 4 molecular subgroups, which earlier you so nicely went through. Let's quickly go through. Poly mutations, let's not worry about. They do well. You can see here the 5-year recurrence-free survival is 96% versus 100%. The DMMR groups, 76, 68%. It's similar whether they received radiation or chemoradiation. Same as NSMBP, the no specific molecular profile. 79 versus 67%, if anything, favoring the chemotherapy. But Dave, take me through this. You allude to the serous. In the P53 abnormal group, chemotherapy 59% versus radiation alone 36%. How do you analyze this data? How do you view it, and then how do you incorporate this into your clinical practice?
Well, we're really looking at, again, the molecular profile. So we have the histology with regards to serous, but all of those are P53 mutated. So again, histology or P53 mutation. So again, showing the clear benefit in a prospective fashion. We had multiple reports of retrospective of the chemotherapy benefit in serous, and now lumping in, the entire P53 abnormal. The utilization of chemotherapy, and again, survival hazard ratio of 0.55 with regards to our hazard ratio. So not only are we seeing benefit in the recurrence-free survival, we're seeing overall survival in this sub-analysis. Now, again, what other groups are going to benefit from chemotherapy? And that's going to be called into question, especially in the deficient population, MMR deficient. And that's what's so exciting about this group of patients, which, we really are looking at better therapies which are being developed. Now, the non-specific molecular profile, the P53 wild type. So those patients who are proficient, and then P53 wild type. Should we also be looking at the adjuvant therapy of chemotherapy in that group, and how much more benefit is that bringing? So for me, that still is the question. Again, all the patients had external beam therapy in this. Really, we need to continue to ask the question, is external beam therapy benefiting our patients in these subgroups, P53 mutated and SMBP?
Yeah, no, that's a nice summary there. And Courtney, tell me a little bit, because here we're talking about chemo versus chemoradiation. You're in the clinic every day. Dave and I are in the operating room. We're in our research meetings. Dr. O'Malley goes on a lot of vacations. No, I'm joking, Dave. But you're seeing these patients day in and day out. What are you seeing differently between the patients that get one modality, in this case radiation, versus chemo and radiation? How are you seeing that, and how do you deal with some of the frustrations that they're having?
I mean, I definitely think when you're using more than one treatment, they're going to have more side effects. But for the most part, our patients who are getting both chemotherapy and radiation, I would say all the AEs are very manageable. As long as you intervene quickly and keep the symptoms under control, usually we're able to get our patients through with very minimal dose delays or dose reductions. And so I wouldn't say there's significant increase in toxicities. And I think when we talk to our patients about the potential benefit and, improving their survival, they're eager to do as much treatment as they can. And if anything, they want to be aggressive, and they're okay with having those temporary side effects. And with the chemotherapy, it seems to be while they're on treatment. And then with the radiation, we have to talk to them about short and long-term side effects.
Yeah, no, that's spot on. And I agree with everything you said. I do worry about the long-term side effects of radiation. And it's not only the symptoms, but as alluded to earlier, a hit on their bone marrow and maybe affect, if they need subsequent systemic therapies, the ability to get full doses there. Dave, you sort of led us into this nicely. And let me talk about this trial, and then I want to hear your analysis of it. This is Keynote B21. It's a trial that was actually just reported out a couple of weeks ago at the European Society of Medical Oncology meeting by one of our friends and colleagues at NGOT, Toon Van Gorp. This was an adjuvant trial with over 1,000 patients, in patients that are high risk for recurrent disease. Let me take you through that. Newly diagnosed endometrial cancer, including carcinosarcomas, no residual disease after curative surgery, but a high-risk subgroup, stage 1 or 2 with non-endometrioid histology, or the high-risk histologies. First time now we're including one of the molecular classifications, stage 1 or 2 with aberrant or abnormal P53 expression. And then surgical stage, stage 3 or 4A disease. Obviously, no prior radiation, no systemic therapy. Patients randomized, all patients received chemotherapy. Radiation was at the discretion of the investigator in both arms. As an aside, that's probably one of the reasons why we're able to accrue so many patients, because there wasn't about the debate about radiation or not. They were all involved. Study arm, investigational arm was pembrolizumab, versus placebo. So as we talked about earlier, Dave, you did the great second line work. We're going to talk about some of the first line work next, but we always want to move it earlier. The question is, are we able to incorporate immunotherapy earlier in lines of therapy? And Courtney, after Dave's done, I want to talk to you about the symptoms here. Dual primary endpoints, disease-free survival and overall survival. This study was also actually simultaneously published same day in Annals of Oncology, so really had an impact in our field, not only in gynecologic oncology, but in all of oncology. Dave, here's the data. Press release months ago said it was a negative trial. We could see here from the ITT population, hazard ratio of 1.02, negative. Confidence intervals crossed 1. But take me through this. The pMMR subgroup hazard ratio of 1.2, not significant. But the dMMR pre-specified subgroup, pre-specified, hazard ratio of 0.31, a 69% decrease in recurrence, disease-free survival in those patients receiving pembrolizumab. Dave, tell me your thoughts and tell me how, if anything, will this affect your care?
Pre-specified, but not allocated alpha, meaning that not you see there's no p-value here, even though the confidence interval doesn't go across 1 in the dMMR. So we were bummed, right? This is a big trial, 1,000 patients all over the world. We're like, it's a negative trial. But once we saw the data and we saw how the dMMR group did, even though it wasn't a statistical outcome. Hello, somebody called. I got it.
If someone was going to get a call, I thought it'd be Dave or I. Courtney, you're pretty confident. It must be one of Dave's patients because you can't get a hold of Dave. So I'm sorry.
So we have the dMMR subgroup. So we thought there'd be benefit here, but we also thought and we saw Ruby and GY18 that there would be benefit in the pMMR group. This, to me, though it wasn't a primary statistical analysis of the trial, goes along with our other data. And a 70% improvement, we really have to see more mature data on this, but we have to talk about how are we going to increase the curative intent in these patients. When we look at the curative intent of these patients, that's really the key. Even though they're advanced stage or a high risk recurrence, can we increase their risk of recurrence by utilizing IO therapy in addition to chemotherapy and the dMMR? I tell you what, many patients outside of clinical trial are being treated this regimen across the country. Now that we have data, I'm going to talk about every one of my patients about using IO therapy and dMMR in a local regional disease.
Yeah, no, that's a good point. And that's spot on. I mean, you're right, a negative trial, but when we look at this data, statistics aside, it's strong. Something that I'm bringing back to my clinic earlier on. As an aside, we'll present some updated data at the IGCS meeting in a couple of weeks. But Courtney, I want to, more importantly, we convince or we talk to our patients and they agree about getting a treatment when there's measurable disease. We look at the CAT scan, we see there's stuff there. Ma'am and their family, we need to give you something. And there's a little bit, I don't want to say a buy-in, but they're more accepting of therapy. Now we're talking about giving an additional therapy with potential associated side effects without disease present. Tell us what's your approach in these adjuvant patients and how difficult do you think it's going to be to incorporate an immunotherapy when they're already getting carboplatin and paclitaxel, maybe even radiation?
Yeah, again, we're not having these challenging conversations because when we talk to our patients about the potential benefit of adding another agent, they're excited that we're having new treatment options that we didn't previously have. And so they're excited to be able to have the opportunity to get more treatment. We talk to them, for immunotherapy, I go head to toe about the potential risks associated with it, but they're just excited to be able to have that treatment option. And we really haven't had much resistance with adding another agent to it, especially when we talk to them about the results that we've been seeing.
Yeah, no, that's spot on. And I use the data. I mean, patients have hesitance, but even with the data, it is a 70% decrease is 70% decrease. Let's
we
move on.
simplify it, but when we make it to where they can understand. But if they just hear that there's any chance of having further improvement in their overall survival or risk of recurrence, then they're usually very open to it.
Yeah, no, I agree. And as an aside, thank you for having these difficult conversations. I know a lot of times our physician extenders are really the first line to our patients' questions. So I know it's a challenging task. I want to go through this slide quickly. This is the NCCN guidelines for adjuvant therapy and also for first line and metastatic and advanced or metastatic disease. Focusing on the right here, and we're going to go through a series of studies looking at the combination of chemotherapy with immunotherapy. Dave, the last couple of years has really, you and I always joke around, you're the ovarian lead for the GOG partners. And traditionally, all the great data was coming out in ovary. We had a great, run for our patients the last couple of years with these large endometrial phase 3 trials that were done. Real quickly, the first 3 trials here, really chemotherapy plus minus immunotherapy for the management of disease in advanced or recurrent setting. And GY018 stands out because it was really statistically designed to look at both groups, the DMMRs and the PMMRs. Ruby looked at dostarlimab as an immunotherapy. Attend looked at atezolizumab. And finally, the DUO-E study, it's similar, but they also had another arm looking at Parp inhibitors. Dave, take us through that in a couple of minutes. And then while you're doing that, talk about the role maybe of Parp inhibitors in this setting.
Yeah, I tell you, GY18 and Ruby coming out at the same time really changes on the same day how we look at patients with DMMR, patient who are recurrent or metastatic. And that day changed how we, I said, drop the mic. Hazard ratio 0.3. We'll look at that data in a second. But really, this in that DMMR patient population, every patient should be encouraged to receive in a recurrent metastatic setting, okay, if they have persistent disease. The PMMR patient population, again, marked improvement in the patient population. When we see the GYN18 data, and you're looking at a properly powered study, which shows a 50% reduction in recurrence. I mean, every patient should have a discussion with metastatic recurrent if they're DMMR or PMMR. Like I used to say in Parp inhibitors in the ovarian cancer space, if you're not encouraging your patient with a BRCA mutation and strongly talking about the possibility of HRD, similar here, DMMR is a drop the mic, PMMR, you have to be talking about them. How much does Parp add in DUO-E? We were missing that arm of just IO therapy with chemotherapy. So I think right now we still have the jury out with regards to the fourth agent, which is a lot for a patient in this PMMR population. In DMMR, I don't think we have a role, and I think the DUO-E data would show that. But is there a certain subpopulation we should be considering PARPs in the PMMR population? That yet is unanswered in my mind.
Yeah, that's spot on. And we're looking forward to IGCS. Actually, I believe we don't know the data yet, but there may be some more subgroup analysis from DUO-E trying to predict which patients may respond to PARP therapy. My view on it is simple. It's going to help some patients. We just need to figure out which those patients are. I also want to highlight, you mentioned this 0.28, 0.31, 0.3. It's pretty cool how that was pretty much aligned with what we saw in the B21 trial that I just mentioned.
Exactly, 0.3. It's amazing.
It's amazing. It's a class effect there. And the 0.64 that we saw with here's the data. I apologize, I didn't have it open earlier. The 0.54 that we saw in GY018 in the PMMRs led to its FDA approval, with the FDA approval also of Ruby as well. But Courtney, we just talked about in the last section, I asked you about 3 therapies: chemo, carbotaxol, and immunotherapy. Now, DUO-E, say it's positive. Now you're going to talk to our patients about 4 therapies, throwing PARP inhibitors in there. Take us through that a little bit with some of the PARP side effects, the IO side effects. You have to be a walking textbook of some of the side effects here. Take us through that a little bit in the conversations.
Yeah, so we definitely make sure that we review all the side effects of the PARP inhibitors, the most common including fatigue, nausea, sometimes constipation, sometimes diarrhea, and then also lab abnormalities with anemia, thrombocytopenia, and neutropenia. But again, having one more treatment option that we can add for our patients is more of an exciting thing and not so much a resistant or a challenging conversation, in my opinion. And so I think it's really how you present it to the patient, have that discussion with them, and then talk to them about some of the side effects that we might expect, and then also include how we're going to help manage them through those side effects.
Yeah, no, that's spot on. And again, the conversations you have are crucial. Well, this has been a great session. Just to review, we talked about the treatment setting. We talked about the molecular testing we do. The performance status matters. We didn't highlight this a lot, but there are some patients that need that little encouragement for treatment. As Courtney, I'm sure you know, sometimes we have to manage a comorbidity. I know at great centers like yours and centers like mine, we have the multidisciplinary approach. We get our nutritionalists involved, our social workers involved.
Physical therapy has been huge at Ohio State too for our patients.
Yeah, and physical therapy, and also investigating better supportive therapies, which I know you guys put more trials on than anywhere else in the country. And then other sites are close, but you do a lot of that in all aspects, not only treatment but supportive care.
Yeah.
The potential AE management. So we really touched a lot of this. It's really been a lot of fun. There's a QR, as you can see, there's a QR code here to claim credit. Dave, Courtney, I don't know if you have anything else to add, but on behalf of all of us, thank you very much for being here. We look forward to consider to analyze the data we've seen, the new data that's out there, and most importantly, figuring out what we can do to better our patients' lives and help them live longer. Thank you so much for being here, guys.
Thank you.
Thank you.